Greetings. Welcome to the Why Midwifery podcast. I am Dr. Tanya Khemet Taiwo, and I really want to give you a holistic view of what we need to improve maternal health outcomes and reduce perinatal disparities. So, I want to start with us thinking about Georgia. We've got Georgia on our minds, and I want to ask you a question. So currently, there are about 600 midwives in Georgia. How many midwives do you think that there were just 100 years ago? Some of you are probably thinking, well, there's 600 now. Maybe it was double, maybe it was triple. But actually, 100 years ago, there were 10,000 midwives in Georgia. And just think about that. From 10,000 100 years ago down to just 600 midwives. And let's look at what's happening in Georgia. So we want to this is part of a survey that was done by the Birthplace Lab, and we have created infographics for every state, and to really move towards looking at what's happening where midwifery is not integrated into the healthcare system. So a lot of times when we think about perinatal disparities, there's a large focus on mortality, the death of Black women and Indigenous women who are dying at astronomical rates. But beyond the 700 to 900 women who suffer from pregnancy complications that result in death, there's an additional 60,000 women who suffer complications that are near fatal that don't get counted, and then many more who suffer unnecessary interventions, like looking at Georgia's um, C-section rate of 33.9%, or even just the US rate of 32%, which is much higher than where we need to be. And we see Georgia, having a higher low birth weight and higher preterm birth than the rest of the country. And if you compare Georgia to states where midwifery is fully integrated, people have better access to care, you see even lower rates. So, a lot of times when we talk about disparities in the US, we use white American women as the baseline. So let's not. Let's actually seat the problem in an international context. So we have in maternal mortality across several countries, and you'll see that what we're experiencing in the United States is not anywhere close. We are in multiples of many of the similar high-income countries. When we look at who is caring for pregnant people in the countries with great outcomes, what we see is that the US, outlined in the orange box there, is one of the countries that you're more likely to have a doctor than a midwife, right? Now, I don't want this to be what I'm saying to be anti-doctor. If I need surgery, I want a highly trained surgeon. If I'm about to undergo a physiologic process like childbirth, I want someone who knows how to care for me and preserve that process. The system works best when there is integration. So, as opposed to low income countries where poor outcomes are the result of too little too late, what we have here in the US is too much too soon. And what we also have is limited support, particularly in the postpartum period. So let's look at when maternal mortality happens. You'll see that 52% of the deaths occur after the delivery of the baby, and during that period when our healthcare system abandons the dyad. Many of you who are listening who have been pregnant and had children have had the experience of being told upon discharge from the hospital, oh, schedule with your OB in 6 weeks. That is not the midwifery model of care that has very close monitoring, close check-ins, and access to your midwife in the days and weeks following your birth. Many midwives in their practice, particularly home and birth center midwives, offer 3, 4, 5 postpartum visits during that 6-week period. So I mentioned the birthplace lab, and I encourage you, if you're interested, to go to the website and check out these maps on the integration of midwifery. And you'll see here that the darker colors are the states where midwifery is fully integrated. What does integration of midwifery mean? Well, it means that you have licensure for the direct entry midwives. You have nurse midwives are able to practice independently to fulfill their scope of practice. There is Medicaid reimbursement for midwifery. There is Medicaid reimbursement for birth that is in the community outside of the hospital, in a birth center or your home. That there are hospitals who have transfer protocols in place that allow, um, not allow, but are welcoming and efficient about how transfers happen when people need to come into the hospital from the home or birth center settings. You'll notice where midwifery integration is better, right? And you'll see the places that where we have the worst outcomes in the South are the places where midwifery integration is the lowest. And if you visit the website, you can see the maps, and you can also look at cesarean rates in relationship to integration, as well as the percentage of Black births that are happening in particular states. So also at the birthplace lab, we looked at mistreatment. And what we found is in this country is that 1 in 6 women experience mistreatment during childbirth. So what does mistreatment mean? It means being shouted at or scolded by a healthcare provider. It means that you are ignored, or your request for help is refused, or there's a um there is an unreasonable amount of time before your request is responded to. And so think about that. In this country, 1 in 6 women in our study, in our national study, experience mistreatment during childbirth. Now, when we look at that experience, for the BIPOC community, we see that the rates of mistreatment are much, much higher for people of color, highest for Indigenous, second Hispanic, and then Black women. So the problem of how we get to disparities is a problem that is seated in the quality of care. Not, and when we say quality of care, we're not just talking about, are there the machines and the medications and the fanciest of expensive medical equipment, but are you treated with respect? Do you have autonomy? Do you have the support you need? Is your experience going to be addressed in a holistic way or not? So enter the Black Mamas Matter Alliance. And they have really done an incredible amount of work around the social determinants of health. So when we go back to the infographic about Georgia, right, we saw that there were differences in breastfeeding rates, cesarean section, um, the having a vaginal birth after having had a C-section, the success rate of that. So we have to think expansively and holistically about maternal mortality and morbidity. And so let's dive into the social determinants of health for reproductive care as defined by researchers at Black Mamas Matter Alliance. The World Health Organization launched its commission on the social determinants of health over a decade ago, and a large body of research has proven that social determinants, defined as the conditions in which people are born, grow, live, work, and age, are significant drivers of disease risk and susceptibility within clinical care and public health systems. Unfortunately, the term has lost its meaning with the systems of care because of misuse and lack of context. As many disparate health outcomes remain, including higher risk of maternal mortality among Black and Indigenous women, a deeper understanding of the social determinants of health and what forces underlie their distribution is needed. I would like us to expand our thinking about the social determinants of maternal health to include terms the structural determinants of health and root causes of health inequity. When we think in this way, structural determinants and root causes will identify racism as a cause of inequities in maternal health outcomes, as many of the social and political structures in the United States were born out of racism, classism, and gender oppression. So when you just take a look at this web of causation, right? And think about how redlining, for example, could contribute to increased maternal and infant mortality and morbidity, right? Think about redlining impacting the neighborhood demographics where you live, impacting the quality of your housing, the quality of your access to education, your access to transfer of care. And so you have you have this one policy that ended years ago, still having a direct impact on that leads to health disparities. So we want to think about how we transform into a system that upholds physiologic birth, right? And so one example is Jenny Joseph, who is a certified professional midwife in Florida and who look is taking care of a primarily Medicaid population. And when we look at her outcomes, you'll see here that the blue bar is Orange County, the county in which she provides services. The red bar is Florida in general, and the orange bar is those people who experience midwifery care in a community setting with integrated with delivery in birth center, in the hospital, and with wraparound services, including doulas. And you see here significant reductions in preterm birth. We spend millions of dollars in taking care of infants who experience preterm birth, and yet still, here is one example of a significant savings in both the human cost as well as the financial cost to the system. And so let's applaud Jenny Joseph, a midwife and leader in our country who is showing us that the midwifery model of care is the way to reduce disparities. So I want to talk a minute bit about the midwifery in the US and the alphabet soup Um, so we have two national certifications. We have the certified professional midwife and who is a direct entry midwife. And then we have the certified nurse midwife, which is, folks who go to nursing school first and then graduate from schools of nurse midwifery. Now, within the direct entry, underneath the CPM national umbrella, we have very different state level designations. In California and Oregon and Washington, we have the credential of the licensed midwife. You may also find states where their direct entry midwiferys are referred to as registered midwife, or states where they're actually just called direct entry midwives. Many midwives will hold the state um, certification, licensed midwife. So I am a licensed midwife, but I also am a certified professional midwife. So when I refer to direct entry midwives, I will use that national certification term. So CPMs, certified professional midwives, provide unique and critical access to physiologic birth that profoundly benefits mothers and babies. And significantly fewer preterm birth and low birth weight babies than for women in hospital care, and many fewer C-sections, 5 to 6% versus 30% of healthy women in hospital care. We have high rates of VBAC success, 87% at home, and much higher rates of breastfeeding. CPM breastfeeding rates range around 97% when at 6 weeks, when the US hovers around, I think we hover around 40% overall exclusive breastfeeding at 6 weeks. So how do we know the benefits of CPM care? Well, there are several studies, but one I really like to refer to is the Strong Start study, which was conducted by the Center for Medicaid Services. It was one of the programs that came through the Affordable Care Act, funded by the Affordable Care Act, that tried to answer the question of what was the best outcome. Where would we find the best model of prenatal care? So you'll see that there were Medicaid enrollees around the country. They were those who were in maternity care homes. So that is hospital-based care that has greater care coordination with enhanced services, perhaps health education, that's coordinated with the prenatal care. Then there were 10,000 enrollees across 60 sites that had group prenatal care. And the majority of these group prenatal care recipients were taken care of by nurse midwives. But yet still, that was in hospital situations. And then we had the birth centers, almost 9,000 enrollees across 47 birth centers receiving the midwifery model of care. Primarily, most birth centers in this country are owned and operated by certified professional midwives. So we had a very strongly representative study sample here, representative of the country, and with a significant portion of the people in the study, 21%, having had a prior preterm birth. And keep in mind that the greatest risk factor for having a preterm birth is having a prior preterm birth. So we did have a population within this study that was at risk of preterm birth. What this study found is that women who received prenatal care in Strong Start birth centers had better birth outcomes, lower costs relative to similar Medicaid beneficiaries not enrolled in Strong Start. In particular, rates of preterm birth, low birth weight, and cesarean section were lower among the birth center population participants, and costs were more than $2,000 on average per mother-infant pair during the birth and the following year. Now, if a person enrolled in a birth center and then needed to transfer to the hospital, they were still included in the birth center group, so that we could see how the benefit from starting your care with a midwife in a birth center, even if you still needed to move into the hospital. You would think that this report came out in 2018, and you would have think that the Center for Medicaid Service would have thought, oh my God, we need more birth centers because we can actually get lower preterm birth, more VBACs, vaginal births after cesareans, and fewer C-sections for less cost. Yet still, the Strong Start study hasn't really moved the needle very much. However, many advocates and advocates are using at the state level are using these results in order to improve the Medicaid services for birth centers and coverage. So I want to just give you more of a definition about certified professional midwives. And we are community-based providers credentialed by the North American Registry of Midwives. So that means whether or not you're working in California or Illinois or Washington State, your credentialing is going to go through the same organization. And then you'll have your CPM and your licensed midwife, or whatever the designation is used in your state. They are a rapidly growing segment of the midwifery population. So 1 in 4 midwives today are CPMs. And CPMs provide maternity care that's health promoting, preventative, and avoids the overuse of interventions. And they're the only maternity care providers specifically trained to provide care in community settings. So while nurse midwives also provide maternity care that is health promoted, preventative, and avoids the overuse of interventions, they are not specifically trained to provide care in community settings. Many nurse midwives will go into midwifery school intending to birth in the clinical setting, and then have to really, once upon graduation, really work on their skills because they haven't been specifically trained in the community setting. And certified professional midwives are independent providers and who collaborate when needed to assure appropriate care. So let's talk about, and I want you to notice that I've wanted to highlight midwives in California. Rasha Tahini Lawler is in Southern California, in Los Angeles. And then here's a picture of Kiki Jordan, who's a midwife in the Bay Area. So what are characteristics of midwifery care? One thing I like to say often and loud, and anybody who will listen to me, that it is evidence-based care. We follow the evidence. Many aspects of obstetrics, the things that we think about, like continuous fetal monitoring, were instituted without actually any solid evidence of their benefit. And then we find out later that electronic fetal monitoring doesn't give us any better outcomes than what midwives have done forever, which we call intermittent auscultation. So listening on a very defined protocol, but it actually just increases the interventions. Midwives facilitate physiologic birth. We have expertise in the home setting and the birth center setting. We provide educational, counseling, and support. Most importantly, the care that midwives provide it really is about the whole person, right? We want to optimize the health of the whole person. And that is the foundation of midwives. Midwives lived in communities, were connected to the community. They knew all of the ins and outs of their clients' lives. And so they were able to pay attention to the individual needs of each childbearing individual and their baby. Continuous risk assessment throughout the course of care is also incredibly important. So that means that we're not spending 5 minutes listening to heart tones, measuring the belly. Are you doing okay? Goodbye. But it's asking questions about, tell me about your diet. Tell me about why your blood pressure is a little bit higher today. Um, tell me more about the stress that you're experiencing, your stress at work. Can we also talk about how, if you're doing physical labor, how we can help you think about body mechanics, right? We are trained also to handle emergencies and provide emergency care until additional assistance is available, and also to really work with doctors when needed. And so what that can mean is, it may mean consultation, and a consultation could result in co-management. It could result in a transfer of care if that's needed. And so people do best when the entire system is working together. So where are CPMs licensed? Well, not everywhere. And and not every state has the same scope of practice. So we have situations where we have midwives in the Western states who are able to carry the medication that's needed to treat a hemorrhage. And we have CPMs who are working in states where they don't have access to that medication. And so guess what? People who are um, in those states who end up having a hemorrhage have a bigger hemorrhage amount, because there's a delay in them getting the needed medication that's just specifically due to licensing restrictions. We have California nurse midwives up until 2 years ago needed physician supervision, and they had a bill that took 11 years to get through the California legislature to remove that physician supervision. So that is a unique complexity that exists in the US, that the state, to integrate midwifery and achieve midwives being able to work at the top of their license within, to maximize their scope of practice, to maximize the benefit, has to happen on a state by state level. And then there's the money. Including community midwives in state Medicaid programs is often fought by the state medical association and the American College of Obstetricians and Gynecology affiliates. So we've had an increase in community-based birth, but we haven't seen, and since the pandemic, we've had a groundswell of support for community birth, a groundswell of desire, but we haven't seen much changes in Medicaid reimbursement. Home births have increased by 70%. Um, and birth center births have more than doubled. And, in 2017, it was 1 out of 62 births was in a community setting, so about 62,000. Um, even even while total US birth declined. So Medicaid only paid for 18% of the births in birth centers and only 9% of the births at home. So we currently have 350 birth centers across 41 states, a 76% increase since 2010, and a desire for people to deliver in birth centers, but not the payment for midwifery that is needed to provide the care equitably. What are the barriers? Are the barriers to improving outcomes? Again, I've talked a lot about the poor integration of midwifery care in the healthcare system, right? And so because of the lack of reimbursement, we have an underutilization of community-based midwifery care. We have a lack of access, both in terms of just the low number of midwives, as well as um, the problem with reimbursement that I talked about. And even in the states where we have reimbursement for midwifery care, Medicaid reimbursement, the reimbursement is low, and midwives are not able to survive, to support their families with with these reimbursements. And then you have tiers. So CPMs and CNMs will provide the same service and then get paid less money. And then also, we don't have enough schools to support the midwives that the folks that want to be midwives. So where are the opportunities for systems change, including CPMs and community settings in emerging care delivery and payment models? This is where we need to advocate. We need, just like why midwifery podcast is happening, is to provide information about CPMs and birth centers. And we need to pay people for the work that they're doing. So and not create these tiered systems of reimbursement. We want to see more of the health maintenance organizations. We want to see more employee-based payment systems contract with midwives and birth centers. And I just want to acknowledge two of our ancestral midwives, Queen Mother Nankululeko and Mama Afua Hassan, who are watching this work, and, telling us, come on now, make this happen. So I'm going to take you back to this workforce slide. This is also needed to improve outcomes, but we are heading to a precipice because the American College of Obstetricians and Gynecologists, ACOG, has projected that there will be a shortage of up to nearly 9,000 OBGYNs, by later this decade. And so the shortage will actually grow to 22,000 by 2050. 35% of OBGYNs are 55 years and older, and half of US counties lack a single OBGYN. Many women who live in rural communities have long treks for care. So the system needs to be training midwives in massive numbers to be able both to fulfill the demand that is there for midwifery, as well as to fulfill the workplace requirements, the workplace needs that are going to be addressed. And so this is why we need systems change to improve outcomes. We also need policies and practices that are going to address the social determinants of health, investing in communities, expanding insurance scope, paid family leave. We need the California Momnibus. It was also passed in 2021, and in addition to exempting pregnant people from CalWORK's welfare to work requirements, also put money into building the midwifery force by establishing a fund for midwifery training programs. We need to see passage of the federal Momnibus bill that has 12 standalone bills, each introduced by a member of the Black Maternal Health Caucus. And so we want to see all of those pass because they really are addressing the social determinants of health. All of the acts are inclusive of the support of midwifery. We also had a success in the passage of the Pregnant Workers Fairness Act in this last Congress, the 117th Congress, that is protecting pregnant and postpartum workers who have consistently faced discrimination in the workplace. So all of these, I know we started with why midwifery, and I quickly went to these pieces of legislation because this is how midwives work. We aren't just interested in the person that's sitting in an exam room that is separate from all of the pieces of their lives. Midwives are interested in, are you getting enough sleep? Do you have stress on your job? Is your job impacting your ability to eat a healthy diet, to prevent complications from gestational diabetes? It's not just about the birth; it's all of the services that that midwives have provided that need to be given in a context that centers the experience of pregnant people in their lives and in their communities. And so I would love to take questions. And I know that we are, this is going to be an ongoing conversation that we're having on the Why Midwifery podcast. Thank you so much for listening to me.